Hi, I'm Dr. Mark Studin, and I'd first like to thank ChiroSecure for the opportunity for me to share information with you today. And today we're going to tackle what's unfortunately become a controversial word in our industry, which is just baffles me. It just boggles me. I don't understand it because it's something we should all rally around, and it's the word subluxation. Let's go to the slides. We're going to talk today about what is subluxation. Does subluxation exist? Is there a more accurate way to describe the core of what chiropractic treats? What is the mechanism of bone on nerve? Those are the things we're going to be looking at today and exploring. Those are questions that need to be answered. So when we look at subluxation, really it's a philosophical origin. So when we look carefully at the vertebral subluxation complex, Leonard Fay in 1966 helped develop that complex. And he described a chiropractic vertebral subluxation or as a complex entity that can block the open quote, close quote, life forces in a biological system. Now, Leonard Fay actually spoke with him a little while ago, and he said he first coined that in 1963. Even though the ICA had a relationship with Joe Felicia and Guy Reekman, they really brought it around the country. And Charles Lance in '89 furthered the concept of a chiropractic or a complex vertebral subluxation or vertebral subluxation complex as a complex clinical entity comprising pathophysiological changes with one or more of the following. And he really furthered it. And this is what Leonard Fay brought out: neuropathophysiology, kinesiopathology, myopathology, histopathology, and biochemical pathology as a result. Now, as in everything in research, and chiropractic is no different, you start out with a question, and then science in the laboratory has to answer that question. So you have philosophical questions that you need answers for. Now, I graduated chiropractic college in '81. I studied with, a whole bunch of people, and I was dying for answers, and there weren't any. All we had then, back in the late '70s, early '80s, was philosophy. There wasn't a whole lot, but that's a whole lot different today. It's a lot different. So really, and I want to put this out there, you have subluxation-based schools who teach subluxation as the core of chiropractic, and then you have anti-subluxation schools who don't even allow the word on campus. And you know what? Both are absurd to an equal polarization, because the reality is we should teach subluxation. We should teach it. We should understand it. However, we shouldn't communicate that because it's not, truthfully, it's not scientifically based. Regardless of what people say, you go on to all the scientific sites, but there is a scientific background for what we do. And I think a better way to report that will help us mainstream. Now, when I say mainstream, am I saying selling chiropractic out? Am I saying changing chiropractic? No. But you know what? I am a primary spine care provider. I want to work with primary care medical providers, orthosurgeons, neurosurgeons, neurologists. I want to work with all of these people. And you know what? I could argue, I don't need them. I'm in my own office. That's great. Guess what? Mainstream medicine treats 98 to 99% of the population. We treat 7, 8, or 9%. I want to tap into what they have so that I can have a waiting list practice. Someone coined that years ago. I want people to run after me. Our school should be bulging at the seams. In your office, someone should have to know someone to get an appointment. But we'll never do that unless we tap into that as primary spine care providers. But let's talk about the science just a wee bit. Now, what causes a neuro-biomechanical lesion? It's pathological. It has a neurological component. It's biomechanically messed up and it's a lesion, or a vertebral subluxation complex. Same thing. So you have hypomobility, hypermobility, inactivity, repetitive asymmetrical movements, macro or micro repetitive traumas, or asymmetrical biomechanical loading due to loss of normal articulation above or below. Remember, The disc is a shock absorber. We have ligaments that hold it, but your fulcrum point is that facet. That's where it articulates. Folks, that's where the magic happens. We're going to talk about that in a little bit. But that magic happens at the facet, and we're going to talk about that. And the ligaments, which a disc is a ligament, is also critical in the model. So when we look at the zygapophyseal joint, and I'm just going to get it right out there. You ready? What happens is you're getting subfailures of ligaments. And by the way, I don't have enough time in 30 minutes to explain this to you. I am giving you broad strokes. And on the second to last slide, I'm going to teach you where you can truly learn and get a real education on this stuff. But what occurs, and if we look at the zygapophyseal joint, and on an MRI, your Z joint is right here on one side and then the other. On the facets themselves, there are nociceptors, which help with the releasing of cytokines, which then go into, and other proteins, which go into the dorsal root ganglia, which go up the spinal thalamic tract, through the periaqueductal gray area, hitting the thalamus, and then going to the anterior cingulate, the prefrontal cortex, and on, bouncing back afferently till it comes back down efferently. So the answer is your bone-on nerve, and we're going to talk about this again in a few minutes. There is bone-on nerve. It's not in the nerve root, and if you understand how to interpret MR in an axial slice, here's where the nerve roots come out, and this is your neural canal. There is no bone-on nerve in the nerve root. Physiologically, it's impossible. But the bone-on nerve occurs in the zygapophyseal joint, which doesn't only affect the nociceptors on the facets, it affects the joint capsule, which we'll talk about in a moment. So what occurs is you have a little meniscoid or plica, which is a spacer. And when you have any one of these causative issues to create what we call a subluxation or pathoneurobiomechanical lesion, I don't care what you call it, okay? Pathoneurobiomechanical lesion or biomechanical lesion are all evidence-based. And I like being mainstream because I want those referrals. And by the way, on our consulting side, right now we've gotten, I'm not going to pull up a slide because I'll screw this whole thing up, but over 1.5 million referrals, predominantly where the referral sources are running after our doctors. Additional referrals only because we've gone after the mainstream based upon the evidence without giving up our chiropractic identity. So what occurs is you get a meniscoid, it comes out and entraps around the facet area and the facet ligaments. And now you have your bone-on nerve right here. But another thing happens. Another thing occurs is that the ligamentous involvement, when that meniscoid or plica is coming out and it's going out, you've got the joint capsule. You've got these ligaments all firing and going upside down. And when that occurs, it creates a significant problem. So you've got a lot of things going on in here that are being released, but we've got to get to here because this is really where the majority of the firing occurs. In that joint capsule, remember, we're looking at not just the meniscoid, but right here, what happens to it when the joint dislodges. So you've got Pacinian corpuscles, which are your crimp receptors. You've got Ruffini corpuscles, which are your stretch receptors. You've got Golgi ligament organs, which sense what's going on within the ligament. And then you've got free nerve endings, not only at the facet level, the nociceptors, but all around, picking up thermal and chemical changes. They all feed into the lateral horn, every one of them. And these comprise of your mechanoreceptors and proprioceptors. So all of these tell you where you are posturally. And then it shoots up into the spinal thalamic tract, through the periaqueductal gray area. It hits the thalamus. And what occurs is it affects all of these areas, all of these functions. And we know through functional MRI, showing where in the brain it lights up when you have an area that's interfered with, or you create a chiropractic spinal adjustment. We know that it affects the cingulate cortex. We know it affects the insular, the motor, the amygdala, the somatosensory cortex. It affects emotions, learning, motivation. memory. It affects consciousness, homeostasis, perception, motor control. It affects so many different things within the human body, which gives us answers. And by the way, folks, it's on my bucket list, and I now have the technology through a device called Simverta, which is a measuring tool. We now have the technology to prove in the research lab, in the scientific arena, that a chiropractic adjustment affects systemic disease. We're a few years away. I haven't found the research team. And if you have a research team that can help us, please let them communicate with me. We've got all the pieces of the puzzle put together. I'm on an active search right now. But all of these things are affected. When you have these areas firing into the different parts of the brain, it goes afferently, and then it ping-pongs off of all of these regions. It ping-pongs off of the insula, anterior cingulate cortex, orbital cortex, prefrontal cortex, motor cortex, sensory cortex, hypothalamus. They ping-pong, and then they go efferently. And guess what? Sometimes it goes efferently to disparate areas. So if you have a problem in the lumbar spine, you're going to have an efferent response or pain in the cervical spine, potentially. Why? Because look at me. We have bones that are lined up. And if you have a bone that's off kilter because because that pleat is out of place, that meniscoid, it doesn't line up even if it's 1 or 2 degrees, then the body is going to have to put curves in there. How does it put curves in there? Because the brain tells if the lumbar is out of position to the right, it'll tell the thoracic muscles to pull on the left, then it'll tell the cervical muscles to pull on the right, therefore giving you your compensatory curves. That's how the body acts. That's why when you treat regionally, it creates a problem. Because you might not be treating the primary area, you might be treating compensation. And it's a huge issue. So actually, that tool we shared with you before, Simverta, will actually show you where the primary lesion is. It might absolutely show you where that primary lesion is. Not mine, it will show you where the primary lesion. It'll tell you where to adjust, when to adjust. It'll tell you about ligament laxity and OMSI, but it's the only tool out there that'll quantify this in an evidence-based environment to tell you what's going on. And that's extremely, extremely important. So what we do then from here is we render a chiropractic spinal adjustment, a high velocity, low amplitude thrust. You have the meniscoid out of place. It's trapped in the joint capsule. When you deliver that high velocity, low amplitude thrust, it separates the facets and allows that meniscoid to reseat itself and stopping the facets from doing that, like cymbals, firing. There's pressure now off. Remember, we say pressure off of, you've got crimp receptors and stretch receptors and Golgi ligament organs. All of these things now normalize. When these things now normalize, all of a sudden you stop that aberrant firing up into the brain. It doesn't go into the lateral horn anymore. So therefore, when that occurs, and by the way, this is from Evans back in 2002. This is 20 years old. I am not breaking new ground here. And I'm shocked the majority of you haven't heard of this before. And I know you haven't because I speak to so many folks. But this is really, it's just a simple, it's a simple concept of what occurs. Now, when we look at this and we talk about this, the releasing the cytokines and then it stops, then the next thing you do is we go to MRI. Here's your facet pre-adjustment. This is your facet post-adjustment, and it gaps. You have residual gapping, which lasts for about 15 to 20 minutes initially. That's the only research I could find so far, and the average residual gap increase is 0.77 to 1.33 millimeters. And then everything, what you're doing is you're adjusting, it's like 1 grain of sand at a time. You're creating a biomechanical change. If the lumbar spine is off kilter 3 degrees, after you replace that pleat, chances are the muscles have been patterned to hold it in the wrong place, or you go back and do the same thing. What do I mean? Woman, high heels, pocketbook on one side, men sit on a wallet. You're working as a dentist, always leaning from one side. You're a chiropractor, always bending over, delivering high velocity thrusts. And by the way, I am a proponent of an arthrostim type device, an electrically powered activator, so to speak. Why? Well, let me tell you, folks. I saw, well, in my heyday, which is, by the way, everything in my life starts with I used to. Okay, I used to run fast. I used to do this, but I used to see 650 visits a week. And I had to stop because I broke my back. I had two compression fractures. I lost 2.5 inches in height. I've had surgery on both shoulders, on my hands. Let's see, I've got a bunch of herniated discs. I had my hip replaced a few months ago, and I attribute it all from adjusting. And I was always a hands-on adjuster. And a few years ago, my elderly mother-in-law, um, she loves chiropractic. She was antalgic like 45 degrees or more. And I couldn't adjust her. I was afraid. I was afraid of, she was brittle. So what I did is I got an arthrostim and I just used Simverta, a device like that to determine where to adjust her. It was 3 areas. It was 2 times AS. I got to get the ischiums in there to adjust them. And 1 area around T11. 2 adjustments. She was 100% upright. I was sold. It was wonderful. So you need to use leverage actually to support you so that you don't hurt yourself. I'm the living proof of we give our all, and I don't want you to give as much as I did. So, and I mean that sincerely. So, folks, here's the evidence. And then when we go into it, I didn't want to get into the weeds too much in this, but this is the most accurate diagnosis you could use. A biomechanical lesion, cervical, thoracic, lumbar, sacrum, and pelvis. Then after that, if you want to do the 5 components of subluxation complex, kinesiopathology, myopathology, histopathology, etc., your next diagnosis can be any of those things. Now you've accomplished the same thing, but you're mainstream. You're not fighting everyone. But by the same token, our academic institutions should absolutely teach vertebral subluxation complex and the 5 components of subluxation, not as a scientific finding, but as the precursor to what science has shown to be true. All of that is true, by the way. It's all real. It's all 100% real, but science hasn't caught up with it in literature. The coding hasn't caught up with it. And don't say, oh, Medicare recognizes it, so it's real. It doesn't work like that. As a matter of fact, I was brought onto a case by the insurance industry on one of our devices. And the device owner whom I spoke with at length multiple times, because my goal was to keep him out of a RICO case and all the doctors that use that device. He said, oh, Medicare pays for it, so we're good, and that's fine, and then everything is good. No, it doesn't work like that. I promise you. The carriers who are going to take you to task don't care either. And by the way, you have to use subluxation to Medicare. I get that. But in non-Medicare cases, I would morph over to biomechanical lesions. I wouldn't use the other any other diagnosis. For me, after 41 years in the game of looking, I would start here, and then I would go on to the effect of the lesion. And by the way, I'd stay away from pain. Pain is what we call throwaway code. I work with Sam Collins a lot, and for me, is possibly one of the most knowledgeable coding people in our industry, or arguably is. He's wonderful. He calls pain a throwaway code. What's causing the biomechanical lesion? Do you have enthesopathy? Do you have a strain sprain, primary? And you've got to quantify that because you can quantify secondary strain sprain in your language. And by the way, just as a side note, if you have strain sprain, that's a permanent lesion that will never, ever, 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 ever get better. And that's evidenced all over the literature. And the main research article is in the Open Rehabilitation Journal 2013. And it talks about it and says, once these ligaments get impaired, they remain that way. And when they heal, which is a bad word, they wound repair, a ligament is made up of collagen and elastin. You have fibroblasts that produce collagen and elastin from the neonate all the way through puberty. Once you hit puberty, those fibroblasts that produce more ligaments, collagen and elastin, go dormant. They don't go away. They become dormant. When they become dormant, they just lay waiting to be used again. So when you have a strain sprain, they get reactivated. When they reactivate, they can only produce collagen, no longer elastin. You ever cut into a piece of steak and see grizzle? That's what you're looking at. So if you have a ligament that's from a mature animal, humans, etc., that's torn. It's going to wound repair only with collagen and no elastin. And the ligament is clear about that. Tozer, all the way back in 2005, said there is no treatment that exists, which is true today, to restore a ligament or tendon to its normal structure. Now, beyond that, when you look at it, and I said before, in a mature animal, and Provenzano in 2002 found through confocal microscopy that even in an immature, a child, 1 year later, it hasn't healed. It's going to remain permanently a mess. And then when that occurs, the ligament wound repairs typically in an elongated position. Now what you're doing is you're going to determine if the joint is pathological. So you're going to do range of motion. And you're going to look at range of motion of the spine, and you're going to say, is it normal and abnormal? Now, in range of motion, you can only use a two-piece inclinometer. A goniometer is only for extremities, and an arthrodial protractor is only good for a doorstop. That's about it. And that's not my opinion. That's according to the American Medical Association Guide to the Evaluation of Permanent Impairment, 5th edition, page 400. It's just simple. However, when you look at cervical spine, you look at it globally, 45 degrees is normal. Now, the problem isn't too little range of motion, folks, because that's usually muscle spasticity. The problem is too much is when it becomes hypermobile. You have 7 segments in your neck. Almost always, what you're going to find is you have 2 or 3 areas compensating for a pathological region. So, in fact, you're going to have 2 or 3 hypermobile areas for that hypomobile area. We have a whole course behind this, by the way. And we use that technology Subverted to determine that. So when you're reporting normal range of motion, when in fact you should be reporting maybe one area is normal, especially if there's spasticity in there, or even after the spasm goes away, then you could demonstrably, and that's the key word, demonstrably show the other areas are not functioning properly. And they're pathological. They're biomechanical lesions, and we could demonstrably show that. And by the way, that validates long-term care. Why do you think the carriers want you to use muscle testing and range of motion? Because it stacks the game in their favor. They're playing with a stacked deck. Muscle test and range, you know what I tell my patients? Mrs. Jones, I can't even start fixing your problem until the pain goes away. What? Because the muscles are spasmed. They're holding everything in the wrong place. When I start relaxing that spasms, now I can start creating some biomechanical corrections. And I can validate that demonstrably using technology. A piece of technology is called Subverta. So we use that technology, and it can validate the necessity for ongoing care. And it'll tell us when it's stabilized. But Mrs. Jones, we know based upon that technology, the ligaments have overstretched. That's a permanent problem. It's called secondary strain sprain. It's a permanent problem. It's not going to get better, but it can be managed. Just like high blood pressure is not going to get better. It can be managed, and we're going to manage it. It's just easy. And managing it could mean you come in to get a chiropractic spinal adjustment maybe once a month, maybe once a year, maybe once a week. I don't know. It all depends on how you present. But we're going to see it. We're going to show it to you. But I can't fix anything till that pain goes away. And when they see that, they go, wow. And they get it. And it works. And you know what? I learned how to share this stuff. It's so funny. My 3-year-old grandson brought me to preschool. They did show and tell. Well, it dawned on me we have to be able to show and tell in a demonstrative way to validate the necessity for care. And it's not muscle testing, range of motion, or leg length checks. You've got to have something that you could show. And by the way, X-ray is the way to show it. Now, I don't want to get into this conversation now, but there is no negative health effect from diagnostic X-rays. That's not my opinion. That is and I don't like to talk in absolutes, but that's the totality of the literature. Now watch. According to the radiological societies and physicists and all this stuff, and that's not what this presentation is about. If you have 100 millisieverts of radiation, which is the measurable dose of radiation, a millisievert. If you have 100 millisieverts of radiation in one setting, because radiation is not cumulative, you have less than 1 in 100,000 chance of having any negative issues. And I'm not talking cancers or things along those lines. A lumbar x-ray is 8 millisieverts. 8. A cervical is a fraction of that. But let's go with lumbar. You need 56.6 lumbar x-rays in one session to have less than 1 in 100,000 negative health effects. How many times have you ever taken more than 56 x-rays in one session in a chiropractic setting? Never. Ever, ever. I've been doing this 41 years. Everybody got x-ray. Never, ever, 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 ever. And if you're using the new filtration systems with the digital systems, it's a whole lot less than that. In cervical, you'd have to take 100 x-rays in cervical. You don't do that. You do the Davis series. You'll do a lumbar complete. That's about the most you're going to do. And now you have evidence in a safe environment. Now, by the way, there are certain political organizations came out and said, oh, you shouldn't do this unless there's a red flag. That's absurd. How else can you see what's going on to diagnose a biomechanical lesion? You can't. If not, you're guessing. You can take a good educated guess, but you don't have demonstrable information. Red flags, which is fracture, tumor, or infection. Those are your red flags. And I'm not really interested in that, even though I can tell you a tremendous percentage of our doctors, and I'm talking, 10, 15%, see pathology. But you shouldn't use x-ray for screening. Well, screening is used for mammography. Screening is used for prostate cancer. Screening is used for colon cancer. Why can't we use it for spine? It just doesn't make sense. But now, how is it going to change your treatment plan? Because when you see those biomechanical lesions, you set your treatment plan. Now, let me give you, you're all biomechanists, all of you. Let me tell you why. You ready? Atlas, left. Spinous right on the axis. Pelvis 2 times PIEX. That's all biomechanical markers. You're all treating biomechanical lesions. But if you don't see, you don't know. And all of those naysayers about x-ray are telling you, unfortunately, to guess. And it's just a shame because it's not giving the entire story to the profession. But I'm going to do that a whole different time. So, folks, what I want to share with you is subluxation is real. Oh, I don't even have my last slide up here. Alan, I gave you the wrong stack of slides. Oh, my goodness. So, folks, if you want to learn more about any of this stuff, you can always call me. My phone number is 631-786-4253. That's 631-786-4253. Or you could go to teachdoctors.com. Teachdoctors.com, and our primary spine care series teaches you all about this. We have a live symposium coming up November 5th and 6th. It's live in New York or live online in your living room, wherever you are, it doesn't matter. Do either one, it's our pleasure. So if you have any questions, give me a call at 631-786-4253, 631-786-4253. I'd like to thank ChiroSecure so much for the opportunity to share. Thank you, and we'll see you in the next chapter.